To that effect, you're going to hear from one of our chief residents, the PG5 resident, Dr. Kakar. Dr. Kakar is going to talk to us about melanoma, and this is a topic that we select from our previous in-training exam scores and from our previous mock oral scores. We pick things that our residents struggle with and didn't do particularly well on, and we use that to guide our curriculum. And so this year we're hearing on a variety of topics, as we always do, from our chief residents. And today you're going to hear about melanoma. Dr. Kakar graduated from Kasturba Medical College in India, did his preliminary year at Brown, and while he was there, interviewed here for a categorical position, and we were fortunate enough to be able to attract him here and matched into a categorical spot. And at this point is one of our PG5 residents who's matched into a minimally invasive fellowship for next year, and we're happy to hear from him today. Thank you.
Thank you for the introduction, Dr. Dent, and a warm welcome to everyone, specifically our applicants. I hope all of you guys have a good time today. For the next 45-odd minutes, I'll be talking about melanoma. My talk is going to begin with the definition of melanoma and the history and epidemiology of melanoma. I'll talk about some of the risk factors and genetic syndromes associated with melanoma before going on to the pathology and the various subtypes of melanoma. This will be followed by how we diagnose and stage melanoma, and then the important surgical concepts, including margins of excision, role of sentinel lymph node biopsy, and treatment options, including surgery for patients not just with melanoma stage 1, but also with advanced melanoma. Before I summarize the talk, I will go through a couple of common test questions as well as a board scenario for the PGY5s. So the definition of melanoma. Melanoma is a tumor that is derived from melanocytes. Melanocytes are cells of neural crest origin. They occur in various parts of the body. 90% of melanomas arise from melanocytes in the skin. However, they can also arise from the eye, the central nervous system, and rare sites like the gallbladder and the GI tract may also be reported as sites of primary lesions. About 4% of patients' melanomas present as metastases, and a primary lesion is never found. The history of melanoma goes back to the days of Hippocrates. The first reported case was by Hippocrates in 460 BC. Mummies in Peru have been found to have metastases upon examination by paleopathologists, and they've been found to have melanotic masses in the skin and metastases in the bones, confirming malignant melanoma in these mummies. John Hunter was the first to operate on metastatic melanoma in 1787. It was first described by Lennick, who's famous also for inventing the stethoscope. He described the melanoma as cancer noir, or the black cancer, and coined the term melanosis in 1812. The first case of melanoma in English literature was described in 1820. It's pretty interesting that in England, the Royal College of Surgeons actually has named a society after John Hunter called the Hunterian Society. There's a museum in England as well after his name. And every 2 years, they have a lecture, a very prestigious lecture, which is called the Hunterian Lecture. And in 1907, William Sampson Handley, in his Hunterian lecture entitled Melanotic Growths in Relation to Their Operative Treatment, he talked about the various principles of melanoma surgery and emphasized the fact that the permeation of lymphatics was the principal agent in the spread of melanoma. And he recommended an excision of the lesion with approximately 1 inch from the edge of the tumor and another 2 inches deep into the subcutaneous fat. The importance of this lecture was the fact that after this lecture, it was the first time that people actually started recognizing melanoma as a surgical problem and recognized the importance of lymphatics in the spread of melanoma. And the margins that he recommended became the basis for surgical management of melanoma for the next 50-odd years before there were more advances in research and studies which have defined the various margins that we use today. Going to the epidemiology of melanoma, it is the 8th most common cancer in the United States. It forms about 4 to 5% of all skin cancers. The 2011 data showed that there were about 70,000 cases in the United States and almost 9,000 deaths just from melanoma itself. There is a racial distribution in incidence of melanoma, it is principally a disease of whites and light-skinned people, and particularly those of Celtic ancestry. And it's 20 times more common in Caucasians as compared to African Americans. Melanoma should be suspected anytime somebody has a mole. However, there are certain characteristics of moles which really sort of raise eyebrows, especially when we see patients in clinic. If a mole has asymmetry, if it has irregular borders, if it has color variegation, and I'll talk about the typical bluish hue that the center of a melanoma has, a sudden increase or change in diameter of melanoma, or any other changes like bleeding, itching, or new onset of pain in our already existing moles should highlight suspicion for a mole transforming into a melanoma. It's much more common in men as compared to women. In men, anatomically, you see more lesions on the trunk and the head and the neck region, while in women, it's mostly seen in the lower extremities. Coming to the risk factors for melanoma, the number one risk factor is exposure to sun. Solar ultraviolet radiation spectrum has two types of rays, UVA rays and UVB rays. The UVB rays are the ones that are responsible for the common sunburn, and they're actually the most carcinogenic portion of the ultraviolet spectrum. The UVA rays have deeper penetration, though, and they actually cause the skin changes, loss of elasticity, and tissue damage. Highest risk is the highest typical patient with a melanoma would be a pale-skinned patient with the multiple freckles, blonde or red hair, and light-colored eyes. Other risk factors include a history of actinic or solar keratosis. This is a benign condition usually seen in elderly, especially around the face and the forehead region, and is characterized by rough, scaly lesions which occur because of sun exposure. This is a pre-malignant condition for melanoma. Other risk factors include previous history of skin cancer, history of peeling or bleeding sunburns. Immunosuppressed patients have a higher risk of melanoma than a normal population. As I'll mention in my coming few slides, there are some genetic syndromes, and there's a family predisposition to melanoma, including dysplastic nevus syndrome, xeroderma pigmentosum, history of giant congenital nevus in infants, and presence of cyclin-dependent kinase 2A mutation. If a patient has already had a melanoma in the past and has had it excised with no recurrence, there is a 5 to 10% risk of developing a second primary in the course of his life. The important thing to remember is that 50 to 75% of melanomas arise on clinically normal skin de novo. Some of the genetic syndromes in melanoma. The first one is the BK mole syndrome, also called the dysplastic nevus syndrome or the familial atypical multiple mole melanoma syndrome. This was first described in the 1970s. It is an autosomal dominant condition and carries a lifetime risk of 10.7% of getting a melanoma as compared to a 0.67% 10-year risk in a normal population. And 100% of people who've got this syndrome usually end up getting melanoma by the age of 76. And as a result, these patients need to be watched carefully and closely by their primary care physician for any change in the moles that they have. Xeroderma pigmentosa is an autosomal recessive condition, which is characterized by inability to repair DNA damage caused by UV light. These patients not just have a high incidence of melanoma, but they actually also have a high incidence of basal cell carcinoma and squamous cell carcinoma as well. Congenital melanocytic nevus, as the picture shows this infant with a large nevus on the back region. It's seen in about 1% of infants in the United States. 15% of lesions in infants occur on the head and neck region. They may be divided into small, medium, or a giant. Giant congenital nevi are more than 8 inches in diameter, and the incidence of that is about 2 in 1,000 infants in the United States. These giant lesions are important because they have a 5 to 8% lifetime risk of transforming into melanoma, which is much higher than the 0.6% which I had mentioned in the previous slide in general population. The fourth genetic syndrome is neurocutaneous melanocytosis. These patients have large, multiple congenital melanocytic nevi and may have benign or malignant tumors of the leptomeninges. Thus, it can be in the brain or in the spinal canal. It is thought to represent an error in the morphogenesis of the embryonal ectoderm. And these infants usually present in the first 2 years of life with neurologic manifestations of increased intracranial pressure, spinal cord compression, or mass lesions. This is an MRI showing the arrows showing the typical melanocytic deposits and tumors in the brain of this particular patient. Coming to the pathology of melanoma, melanoma is basically an abnormal proliferation of atypical melanocytes near the dermal epidermal junction. There are 4 pathological types of melanoma, and this is a common question that appears on the app site as to which is the most aggressive form. The 4 pathologic types include superficial spreading, nodular, lentigo maligna, and acral lentiginous. The superficial spreading one is the most common. It comprises 70% of all melanomas. The lesions can occur anywhere on the body except the hands or the feet. These are flat lesions, usually about 1 to 2 centimeters in diameter. They have a long radial growth phase before growing down vertically into the subcutaneous tissue, and as a result, they usually carry a good prognosis. This picture shows a typical superficial melanoma, and as I was mentioning a few minutes ago, the center of the lesion has a bluish hue to it, and when you do dermoscopy, dermatologists do dermoscopy, which I'll talk about, this particular bluish hue gets highlighted and helps them in making a diagnosis of the same. Nodular melanoma, this is the most aggressive melanoma. It comprises 15 to 30% of all cases of melanoma. These lesions are generally darker, they're raised. They have vertical growth phase is much more important in these as compared to transverse growth phase. They actually do not grow outside the area of their vertical growth phase. And because of early vertical growth phase, they carry a high risk of metastases, and they're actually the worst prognostic melanomas, and they are the most aggressive as well. Lentigo maligna melanoma comprises about 4 to 15%, mostly seen on the neck, face, and back of the hands, mostly seen in elderly. They tend to be large, about 3 to 5 centimeters in diameter before a diagnosis is made. These lesions also have a very early radial phase, and they usually tend not to grow deeper, and they actually have the best prognosis. For the PGY5, this particular picture is important because the head and neck of the face, head and neck and face melanomas is a board question, especially with regards to its sentinel lymph node biopsy and lymph nodal distribution. And I'll be coming up with a clinical scenario about that towards the end of this talk. Acral lentiginous melanoma is the least common. It's about 2 to 8% of all cases of melanoma. It's usually seen on the palm, soles, and subungual location. It's mostly seen in darker people. The subungual melanoma, as shown on the left, is characterized by longitudinal ridges of the nail as well as darkening in the base of the nail fold, and that sign is also known as the Hutchison sign. These patients also develop a lot of freckles, and those freckles are also named the Hutchison freckle. How do you diagnose melanoma? The primary screening diagnosis obviously is by examining the skin. Clinical exam in experienced, I wouldn't say experienced hands, but in experienced eyes can make a diagnosis in about 65% of cases. Dermoscopy, which is usually used by dermatologists, improves this by about 10 to 15% increases to about 75 to 80%. The procedure basically involves covering the lesion either with mineral oil or alcohol or water, after which a specific instrument called dermatoscope is used, which provides a magnification that's about 100-fold, and it allows the pigmented structures within the epidermis, the dermo-epidermal junction, as well as the superficial dermis to be seen more easily. This is a dermoscopic examination view of a melanoma. The typical appearance of irregular borders, and as I was mentioning, the bluish hue in the center caused by the presence of melanophages. As I said, the dermoscopy is mostly used by dermatologists. Eventually, most patients that we get referred to would be referred to for a biopsy of an atypical lesion. Biopsy guidelines. An excisional biopsy is the best biopsy for a melanoma because it removes the entire lesion, helps us stage the melanoma with regards to its thickness. The depth of the biopsy should include the subcutaneous fat with complete removal of the entire lesion. If the lesion is large, and a complete excisional biopsy initially would leave a large cosmetically inappropriate defect, then a punch biopsy can be taken. The punch biopsy should usually be taken from the thickest portion of the lesion, and it should avoid all areas of crusting or necrosis. We often get patients who have had shave biopsies done by their dermatologists, and shave biopsy is sort of frowned upon because of two reasons. One, it doesn't take the whole lesion, and as a result, it makes the pathologist's job difficult to see what the exact depth of the melanoma is. And the other reason why a shave biopsy is frowned upon is because the shave biopsy essentially needs to be closed with secondary intention, and as a result, it leaves a scar. There are papers that are coming out that deep shave biopsies can be appropriate for melanomas. However, till it's not recognized and there are no randomized trials for the same, I think for present purposes, excisional biopsy or punch biopsy is the answer for a melanoma. Prognostic factors when a patient presents to you with melanoma. The two most important prognostic factors are tumor thickness, that is the depth of the tumor and how deep it is spread, and lymph node involvement. Actually, lymph node involvement and the sentinel lymph node status is the #1 prognostic factor, and that also is an ABSAT question that comes up pretty often. Other prognostic factors include distant metastases, presence of ulceration, which has been shown to be associated with a high risk of local recurrence, mitotic rate, lymphovascular invasion, age of the patient, histological type of melanoma, obviously the nodular because it spreads vertically, having the worst prognosis. And some new molecular markers have also been studied and are actually being studied to prognosticate patients with melanoma. Dr. Clark, who was a pathologist at Mass General Hospital in 1969, he came up with the first classification of melanoma, which was based on the tumor invasion vertically with regards to the anatomic layers of the skin. Level 1 was limited to the epidermis. Level 2 extended to the papillary dermis. Level 3 completely filled the papillary dermis and reached the interface between the papillary and the reticular dermis. Level 4 was extension into the reticular dermis, and level 5 was beyond that into subcutaneous fat. And just a picture representing the same. Level 1 is the epidermis, 2 is as it invades the papillary dermis. Level 3 is at that black line that demarcates the separation of the papillary and the reticular dermis. Therefore, level 4 is deeper into the reticular, and level 5 is into the subcutaneous fat. This was followed by the BRESLOW classification that came the next year, and the BRESLOW classification was based on vertical thickness of skin in millimeters, and it took patients and divided them into level 1 being less than 0.75 millimeters thick, level 2 between 0.76 and 1.5 millimeters, level 3 was 1.6 to 3, and level 4 was more than 3 millimeters. This particular picture is important and shows why the BRESLOW classification is a much more reliable classification. On the left of the picture, you can see the Clark level, and on the right is the BRESLOW level. Now, based on the anatomical location of the lesion, the skin may be thick or thin, and as a result, the thickness of the reticular dermis or the papillary dermis may differ. And this can change the prognosis of melanoma, especially if the pathologist uses the Clark level. It's not an accurate level. That's why the BRESLOW classification is what is being used for prognosticating and for staging melanomas. A little bit of a complicated slide on staging the TNM staging of melanoma. The important thing to know, the T stage is based on the BRESLOW classification, as I mentioned, and there is a component of T, A, or B based on whether or not ulceration is present. The N stage is based on lymph node spread, with N0 being no lymph nodes, N1 is 1, N2 is 2 to 3, and N3 is 4 plus metastatic lymph nodes or matted lymph node, or what's called in-transit metastases, which I'll come to later on. The nodal status further is divided into A or B based on whether it is micro or macro metastases. The M is based on the metastatic spread, and even in that, the location of metastases has a prognostic importance and plays a role in staging, with M1A being skin, subcutaneous, or nodal metastases, M1B being lung metastases, and M1C being any other visceral or distant metastases. Several biological markers and molecular markers were studied to see if any of those would help in staging of melanomas. This included LDH, which turned out to be used in the TNM classification. Some of the other ones that are used are S100 or neuron-specific NLAs, but in large studies they haven't been found to affect staging or affect prognosis. From a surgical standpoint, the important things about a melanoma are, one, what margin to use, and two, with regards to the lymph node status and doing lymph node surgery. The first topic amongst the two is the margins of excision. As I mentioned after his Hunterian lecture in 1907, the surgical margin typically used to be 3 to 5 centimeters or a couple of inches as described, followed by a skin graft on the site of excision. A lot of studies went on to see if this could be reduced because it was obviously a cosmetically disfiguring procedure and also carried with this risk of skin graft-related complications, etc. One of the landmark trials that studied margins of excision was the intergroup melanoma trial. It was in 4 countries. They used 93 surgeons in 77 institutions in the United States, Denmark, Australia, and Canada. They basically decided to see if for melanomas between 1 to 4 millimeters, whether a 2 centimeter or a 4 centimeter margin would be appropriate. The aim of which obviously was to lower down the size of excision as much as possible. They took 740 patients. They about 2/3 with melanomas in the trunk or proximal extremity, and 1/3 had head and neck or distal extremity melanomas. And they found that the 10-year survival, whether you took a 2 centimeter margin or a 4 centimeter margin, was not statistically significant, irrespective of whether the lymph node region was observed or if these patients underwent a complete lymph node dissection. Local recurrence in the 2 groups was 2.1 versus 2.6% at 10 years. Local recurrence being defined as recurrence of the lesion within 2 centimeters of the margin of excision. They concluded that 2 centimeter margin was safe in melanomas between 1 to 4 millimeters. And it was actually this study that also highlighted the fact that ulceration was an important prognostic factor for local recurrence, and it was about 6 times higher if the primary melanoma was ulcerated, irrespective of whether you took a 2 centimeter or a 4 centimeter margin. For thin melanomas, which is defined as melanomas less than 1 millimeter, they actually carry good prognosis. The WHO melanoma group decided to study whether you needed 1 centimeter or a 3 centimeter margin. Their cohort of patients was for melanomas less than 2 millimeters. However, in their subset analysis, when they looked at all those patients with even thinner melanomas, irrespective of the margin, there was no local recurrence if it was less than 1 millimeters. And as a result, they concluded that margin of 1 centimeter was safe and provided excellent local control. It reduces the morbidity of the procedure, and also the patients don't end up needing a skin graft. So for 1 millimeter melanomas and less than 1 millimeter melanomas, the diameter or the margin should be 1 centimeters. Between 1 to 2 millimeters, the National Comprehensive Cancer Network guidelines suggest that the margins can be 1 to 2 centimeters based on the anatomical location. If it's the trunk, you can take 2 centimeters. If it's on the face, obviously, you'd like to take much smaller margins. For thick melanomas, they carry pretty poor prognosis. Melanomas greater than 4 millimeters. There was a multi-institutional retrospective review of close to 300 patients with melanomas more than 4 millimeters. And there was no significant difference in local recurrence, disease-free, or overall survival if margins more than 2 centimeters were taken. And several other studies have also tested whether or not fascia should be as part of your excision, and there have been no differences in recurrent rates, local or distant, whether fascia was included in the specimen or not. So just to summarize, the thickness, if it's a melanoma in situ, it should be about 0.5 to 1 centimeter, again, based on the location. For melanomas up to 1 millimeter, the excision margin should be 1 centimeters. For 1.1 to 2, it should be 1 to 2 based on NCCN guidelines. Any melanoma above 2 millimeters, you should at least get a 2 centimeter margin. When a patient presents for local excision initially, the first step is an excision with a 1 to 2 millimeter margin. You don't want to excise the entire specimen with a large margin, because if you take a wide excision, it impairs your ability to do a sentinel lymph node biopsy. The specimen is sent for permanent analysis, and based on the thickness, the re-excision is performed. Again, re-excision would obviously depend upon how thick the melanoma is, as suggested by the pathologist, and then you'd go ahead and excise with the appropriate margin. Sentinel lymph node biopsy, whether or not to do it, depends upon the thickness of the lesion, and I'll mention that in my next slide. The orientation of biopsy, specifically in an extremity, should be parallel to the lymphatic drainage. One of the more controversial topics in melanoma surgery is the role of sentinel lymph node biopsy. There are surgeons, even to date, who do not believe in doing sentinel lymph node biopsy for the same. With regards to what's there in published literature in the past, every patient used to just get elective lymph node dissection for staging. There were several trials which failed to show benefit of the same. Sentinel lymph node biopsy was first introduced in the 1970s by a surgical resident for penile cancer and has been actually now used for breast cancer and other cancers as well. It involves doing a preoperative lymphoscintigraphy and then using intraoperative blue dye to help in finding the sentinel lymph node. Anatomically, what the sentinel lymph node is defined as the first nodal basin wherein the lymphatic drainage from a particular lesion would be. And the reason why we do sentinel lymph node biopsy for various tumors is because it's hypothesized that if the tumor is negative or that particular lymph node is negative, then obviously it means that there's not been any distant spread beyond that. As I mentioned, and another important factor, remember that the sentinel lymph node status is the most powerful predictor of overall survival in several trials on melanoma. The landmark trial of this was the multi-center sentinel lymphadenectomy trial. This was a prospective randomized multinational trial to address the therapeutic benefit of sentinel lymph node biopsy. They used about 1,200 plus patients with intermediate thickness melanomas. In their group, the melanomas were 1.2 to 3.5 millimeters. Just to go through this, I don't think it came out too well. 60% of patients amongst the 1,270 odd underwent randomization to wide excision and sentinel lymph node biopsy, while 40% of patients assigned to wide excision and observation. The patients who underwent a sentinel lymph node biopsy, if the lymph node was positive, they underwent an immediate complete lymphadenectomy, and if the lymph node was negative, they were observed for future occurrence of nodal lesions, at which time they underwent lymphadenectomy. The patients who underwent only wide local excisions, they were watched for nodal recurrence. They did not undergo sentinel lymph node evaluation, and they underwent delayed complete lymphadenectomy if their nodal recurrence were to happen in future. MSLT1 was started in the 90s. The 10-year data came out in 2006. Initially, before that, in 2001, they came out with the 5-year data, which showed that the 5-year disease-free survival in the sentinel lymph node biopsy group was slightly higher as compared to the observation-only group. However, one fact to highlight in this trial was that there was no melanoma-specific survival. So whether or not you do a sentinel lymph node biopsy, it does not affect survival with respect to the melanoma itself. However, in the 60% patients who were randomized to receive the sentinel lymph node biopsy, their sentinel lymph node status, when they studied that, it became the most important prognostic factor predictor of overall survival. 5 years of tumor-positive sentinel lymph nodes survived about 72%. If their tumors were negative, there was a 90% 5-year survival. With regards to thin melanomas, less than 1 millimeter, the nodal involvement is seen only in 5% of patients. So if a patient presents with melanoma less than 1 millimeter, it's sort of a question mark as to whether or not you should do a lymph node biopsy on these patients. Some of the high-risk features which should guide the surgeon to performing a sentinel lymph node biopsy include presence of vertical growth phase, Clark's level 4 or 5, that is if it extends into the reticular dermis or beyond, ulceration of the primary lesion, regression or high mitotic rate, and if the patient is young. From a statistical number standpoint, the important thing to remember is that there is a false negative sentinel lymph node biopsy. It's in the range of up to 3%. Thus, there should be a discussion with the patient about the pros and cons of the procedure. And if they have any of the high-risk features, then it's recommended that a sentinel lymph node biopsy be done even for thin lesions. For thick melanomas, as I mentioned, their 5-year and 10-year survival is pretty dismal, 45 and 39% as compared to 90% if your sentinel lymph node was negative. The benefit for doing a sentinel lymph node biopsy in thick melanoma is twofold. One, it does help in accurate surgical staging. And two, if your sentinel lymph node is positive and you go on to do a lymphadenectomy at that time, it's an easier procedure than if they were to present several years later with bulky metastases and metastases which would be adherent to nerves or vessels, which would make surgery obviously a difficult proposition. How do you do a sentinel lymph node biopsy? It basically involves, as I was mentioning, preoperative radiolymphoscintigraphy, and in the OR, blue dye is injected around the lesion, and then based on the pre-op lymphoscintigraphy and the blue dye, you perform incision over the lymph node drainage basin and find the first lymph node with the use of a handheld gamma probe. The role in melanoma is, besides staging, is fourfold. There is a role of therapeutic lymph node dissection, and there will be data that I'll present in a couple of slides wherein patients even with stage 3 and stage 4 melanomas who've had lymph node dissection and complete lymphadenectomy have gone on to have a 5-year survival of as high as 40%. It identifies candidate for adjuvant treatment, either with melphalan or with interferon alpha, and it also helps to identify populations to enter into clinical trials. Lymph node dissection, therapeutic lymph node dissection is done for patients with clinically evident regional lymphadenopathy. As I was mentioning, it helps in local regional control. It makes the surgery easy as compared to waiting for them to have bulky mets. And there is a chance of cure. 5-year survivals of as high as 40% have been obtained. Meyer in Germany performed 144 therapeutic lymph node dissections in melanoma patients, and in his series he found a 5-year survival of 30%, irrespective of the stage of the melanoma. Axillary lymphadenopathy involves resection of level 1 and level 2 lymph nodes, and level 3 if they are palpable, the levels of lymph node being with regards to whether they are medial or lateral or behind the pectoralis minor. With regards to inguinal lymphadenopathy, this is also a controversial topic as to whether or not just to do a superficial lymph node dissection or go ahead and do a deep inguinal and an iliac lymph node dissection or not. Surgeons, a lot of places use the Cloquet's node as their guidance. If the Cloquet's node, which is the highest lymph node in the superficial basin in the apex of the femoral triangle, if that is positive, surgeons would go ahead and do a deeper dissection into the iliac and the deeper inguinal lymph nodes. The sensitivity of that is about anywhere from 60 to 90% based on what series you read. For patients with metastatic melanoma, especially with melanomas with what's called in-transit metastases or satellitosis, the concept of isolated limb perfusion was introduced in Tulane in 1958. What in-transit disease or satellitosis is recurrence or metastasis disease in the skin and subcutaneous tissue from a limb proximal to the site of the first lymphatic drainage basin. This concept of isolated limb perfusion was developed because even though surgery is the first-line therapy for these mets, sometimes patients can present with pretty large, bulky mets involving a large area of the limb, in which case it would be cosmetically disfiguring and it would also lead to a big surgical incision. Isolated limb perfusion basically uses the principle of cardiopulmonary bypass. It completely isolates that particular limb from the rest of the circulation. Chemotherapeutic agents are injected into the same with lower risk of systemic toxicity because they are not allowed to enter the systemic circulation. Addition of mild hyperthermia of the limb up to 39 to 40 degrees has been shown to improve the efficacy of this procedure. The standard drug of choice is melphalan. There are places which use TNF-alpha in association with that, but there's no real study that shows any benefit of the same. And concentrations of about 15 to 25 times greater than systemic administration can be achieved with this procedure without the systemic side effects of the same. Sort of a complex setup, but just to explain it in an easier term, it uses cardiopulmonary bypass. So the blood from the patient's circulation at the extremity is obtained by making cut downs on the artery and the vein. In case of the lower extremity, it's usually the iliac vessels, the external iliac vessels. In case of the upper extremity, it's usually the axillary vessels. The blood passes through a bypass pump where it gets mixed with the chemotherapeutic agent, and then it flows back into that particular limb. Usually a 60-minute perfusion time is performed, and there is a probe that is used to check for leakage, and it utilizes radiocolloid to detect the presence of any chemotherapeutic agents into the systemic circulation outside of the extremity circulation. And ideally, the amount of chemotherapeutic agent leaking into the systemic circulation should not be more than 5% of what's injected. If any time they detect that it's more than 5%, then that procedure is stopped immediately. Adverse reactions, obviously, it's taking in pretty toxic medications and injecting directly in high concentrations into the extremity. And most patients do have some degree of complications. The complications are divided into a 5-grading system. The local complications or minor complications are 1 and 2, which is no reaction or slight erythema or edema. 3 is considerable erythema with blistering, while 4 is extensive epidermolysis with definite functional disturbances or compartment syndrome requiring fasciotomies, and 5, which is the most dreaded, is the need for amputation. Isolated limb perfusion was developed in the 50s, and it got utilized in the US much less than in Europe, and most of the studies for benefits as well as complications are European-based studies. Again, a study by Meyer at the same hospital in Germany. This was a retrospective study. They followed 101 patients between 1993 and 2002, so about a 10-year period. And 90% of these patients had stage 3 and 10% had stage 4 melanomas. They had complete response rate in almost 60 out of the 87 patients that were available for evaluation at the end of the 10-year period, complete response being that the lesion had completely disappeared. Grade 4 of 5 complications occurred in 5 patients. Specifically, 4 of them required a fasciotomy and 1 patient required an amputation. So the amputation rate being about 1% if you take the whole 100 patients. To make the procedure easier and to not use cardiopulmonary bypass, in Australia there were several studies done, and Thompson and Sydney came up with a minimally invasive, less complex procedure called the isolated limb infusion. This basically does not use a bypass pump. All it does is they put a tourniquet on the extremity. They use Seldinger technique to place catheters percutaneously into the artery and the vein, and then the chemotherapeutic agent is infused and allowed to run in for about 30 minutes, after which normal saline infusion is given to wash the rest of it off. The medications used are mostly melphalan and actinomycin D combination, and response rates have been equivalent to isolated limb perfusion. One of our own surgical oncologists, Dr. Santillan, did a study while he was a fellow at Moffitt Cancer Center. He did a retrospective evaluation of about 170 patients who underwent isolated limb infusions in 8 centers between 2001 and 2008. Mild complications, which were the grade 1 and grade 2 complications, occurred in about 68% of cases. Grade 3 or 4 complications occurred in about 32% of cases, and actually only 1 patient in this 171 patient group ended up with an amputation. Their way of doing the procedure, or his study, was he found that a lot of places used papaverine prior to infusion of the chemotherapeutic agent to cause vasodilatation. And he found that the use of papaverine, female gender, and if the patients ended up with high serum creatinine kinase, this was associated with higher limb toxicity. With regards to role of surgery in patients who present with advanced melanoma, that is stage 3 or 4 melanoma, as I was mentioning, stage 3 of melanoma, the typical prognosis is pretty poor. Their 5-year survival is in the 30% range, and their 10-year survival is in the 40% range. If they have lymphadenectomy for nodal disease, they will survive about 25% for 5 years. Meyer had a 30% survival. If they have recurrence at any other distant site, it can carry an even much more poorer prognosis of about 5%. So the question then comes is, why do surgery at all for these patients? Surgical options and why we do surgery in these patients: it can be done for curative procedure, it can be done for palliation of symptoms, and it can also be done for immunotherapy, as I will mention in a couple of minutes. From a curative standpoint, factors associated with improved survival in stage 3 and 4 melanoma patients who undergo surgery include ability to achieve complete negative margins of primary lesion, location of the metastases, and that is an extremely important point of curative surgery, extent of metastatic disease, disease-free interval after surgical removal of the melanoma, and stage of the initial disease. With regards to location of the metastases, favorable survival is seen if the metastases are located in the skin, subcutaneous tissue, or lymph nodes, or the lung or the GI tract. Unfavorable metastases with a 5-year survival of about 3% is seen if they have metastases in the brain, the adrenal gland, or in the liver. So that's doing surgery for a curative purpose. What about palliation? Palliation helps to relieve symptoms that are either caused directly by the tumor or by metastatic tumor deposits. Patients can have, if they have upper extremity melanoma with axillary mets, they can have large mets causing sensory and motor symptoms with compression of the axillary vessels in the axillary nerve and the brachial plexus if it's in the neck. GI tract metastases can cause the bowel obstruction. The upper picture here shows a intra-op picture of a patient who presented with bowel obstruction and was found to have multiple melanotic deposits on the surface of the intestine. And single brain metastases, if they are located in the favorable spot like the temporal lobe, some of these patients have had undergone a temporal lobectomy with a good functional outcome. Cytoreductive surgery. Cytoreduction is done. Cytoreductive immunotherapeutic surgery basically means removing the entire burden of tumor, including all the metastases. People have hypothesized that this may allow the patient's host immune system to overcome the tumor-induced immunosuppression. Meyer had a 30% survival after 5-year survival after doing lymphadenectomies. Morton went on to do similar studies, and he also had 5-year survival rates of as high as 40% in stage 4 melanoma patients with cytoreductive surgery. A area of future interest in melanoma and what is being studied is immunotherapy, which is using immunotherapeutic agents either alone or in combination with chemotherapy or radiotherapy to see if they would have any benefit for advanced stage melanoma patients. The 5 immunotherapeutic agents that have been studied and are still an area of active research. The first one is cytokines, of which high-dose interferon alpha is the only FDA-approved agent. High-dose IL-2 is also used and actually also appears on the boards or the app site as being used for adjuvant therapy for melanoma. Monoclonal antibodies targeting T cells and melanoma surface antigens. Adoptive cell transfer in patients with lymphodepleted melanoma patients. You can infuse autologous T cells to see if that would help them fight the melanoma. Vaccines are being studied to see if there would be a vaccine that might help in patients with advanced melanoma for cure. And the last and the most modern of this is molecular targeted therapy, identifying gene mutations like BRAF and NRAS mutations. These are mutations in cell signaling pathways which might be affecting melanoma patients. Before I summarize the next couple of slides, I'll just go over a couple of common test questions and then a board scenario for the PGY5s. The first question is: a patient presents with a non-healing wound which is 2 centimeters in diameter on the plantar surface of the left heel. You do a biopsy and it confirms a melanoma and the thickness is 1.5 millimeters. There is no obvious groin lymphadenopathy. The surgical management would include which of the following? The answer would be A. It's more than 1 millimeter, so you would do a 2 centimeter margin and you would do a sentinel lymph node biopsy as well. Another question that usually appears is which of the following is true for biopsy of suspected melanoma? Whether incisional biopsy is not acceptable, incisions should be longitudinally oriented on extremities, shave biopsy should be performed for lesion in cosmetically sensitive areas, or that a punch biopsy should never be used. B is the answer. The third one, this is sort of an interesting question. A 60-year-old man presents with a lesion in the middle of the back. You do a punch biopsy because it's a large lesion and it shows a 3 millimeter deep melanoma. What would be the next most appropriate step?
None of the above.
None of the above. The patient, when you have a lesion in a region like the back where you don't really know where the lymph node drainage basin is, the answer should be pre-op lymphoscintigraphy to find the sentinel lymph node. And then you would be doing a 2 centimeter, the excision with a 2 centimeter margin, and then a sentinel lymph node biopsy based on where the lesion is located. For the boards, as I had shown the slide on the LENTIGO maligna melanoma on the face, head and neck melanomas can appear on the boards, and there could be a whole 30 to 45 minute talk just on them because they behave and they spread differently as compared to some of the extremity melanomas. The important concepts to remember is that sentinel lymph node in case of a head and neck melanoma can be very close to or occasionally can be beneath the primary itself, and thus when an excision of the primary lesion is performed, care should be taken to examine the area right below it because the sentinel lymph node can be right beneath the lesion. The sentinel lymph node, especially in preauricular lesions, can be within the parotid gland itself, in which case a preauricular vertical incision is made, skin flaps are raised to locate it within the substance of the parotid gland. In head and neck melanomas, if a sentinel lymph node is positive, then they should undergo a modified radical neck dissection on that side. And the last and a pretty important question, which I've seen on the CSAP as well, is that if the sentinel lymph node is positive and is located within the parotid, what should be the treatment? The treatment should be a modified radical neck dissection on that side, but these patients should also undergo a superficial parotidectomy at the same time. So to summarize, there's a correlation between moles and melanomas. The ABCD of moles is really important. Most patients have light-colored hair and fair complexions. There is a familial predisposition and some genetic syndromes associated with melanoma. It's seen more in men and heavy smokers. Wide excision should be performed at negative margins to improve long-term survival. Appropriate surgical margins have been defined based on various trials. The role of sentinel lymph node biopsy, even though controversial, is important in staging and guiding therapy. Surgery may have a role not just for palliation, but also for cure even in metastatic melanoma. And there's continued research focused on the development of novel treatment strategies for melanoma. And as I mentioned it, and as Dr. Dent mentioned before, why we chose this topic is because it always appears on the ABSite and also gets questioned on the boards. At this point, I will take any questions.
Dr. Prasanna.
That was a nice review. But let me add two little things that are peculiar to melanoma. We should know. One is, even though we can look at statistics, the behavior of the melanoma in each particular patient is totally unpredictable. You may have two individuals with identical lesions in the same part of the body, the same depth, treated the same way. One of them may be dead, full of melanoma 3 months later. The other one can be sending you Christmas cards every year for the next 20 years and then explode. The second feature that is peculiar to melanoma is that in addition to going to all the traditional metastatic sites, lymph nodes and the 2Ls and the 2Bs, melanoma is also the all-time champion for metastasizing to places that are weird and stupid and no other self-respecting tumor will ever go to. And you can see that if you look at it the other way. For instance, which is the most common metastatic tumor to the wall of the left ventricle? Melanoma. Which is the most common metastatic tumor to the wall of the duodenum? Melanoma. Two interesting little features.
Dr. Dent.
Why does anybody know, and I don't know, why is ulceration an independent risk factor for poor prognosis? Is that just because the biology of that particular tumor is it grows so fast it outgrows its own blood supply? It's
the biology, and it's presumed that because it's already ulcerated means those cells on the surface have already been destroyed and it's already extended down into a vertical growth phase down into the deeper tissues, therefore increasing your BRESLOW level of thickness.
Dr. Kshitij.
Actually, getting on this topic of ulceration, so you mentioned that there is no trial showing elective lymphadenectomy had any benefit. In fact, there is a trial, and that was the Balch's trial in the late 90s, which he published in Annals of Surgery. And what he did was, it was a large trial randomizing patients to either elective lymphadenectomy or not. And the overall result of the trial was negative. But then what he did is he went and he looked at subsets of patients, and he found that patients under the age of 60 with ulcerated tumors benefited from elective lymphadenectomy. Now, it wasn't a pre-planned analysis, and people have, and of course, the reason he probably found that result, and this has been kind of established now, is that he probably looked at multiple subsets, came across this one. We've talked about this, type 1 error issue, but that was reported widely, and was ulcerated lesions in patients under the age of 60 who benefit from elective lymphadenectomy. And so, since that paper was published, people have realized that ulceration in itself has a high mortality rate associated with it, and the potential for elective lymphadenectomy in that subset of patients. But again, it was probably a type 1 error because he looked at multiple subsets.
Dr. Kshitij, is it true that this lesion is the number one as far as increase in prevalence in the past 30 years, as far as cancers?
It is, yeah, it is. It's
Talk
most,
about the
it was most rapidly increasing in terms of incidence so one out of every, I think the figure now is 1 out of every 50 people will end up with melanoma during their lifetime.
Dr. Stewart, and since there's a subset who respond to immunotherapy, are there any ongoing trials for high-risk groups prior to diagnosis? In other words, true vaccination for melanoma?
I'm not sure. There are most of the trials are looking at therapeutic vaccinations. Actually, vaccinating as prophylaxis, I'm not aware of any right offhand.
That was a fair-haired Australian. I'd be looking for the vaccine.
In answer to Dr. Stewart, a lot of work was done on vaccine in California, but it didn't fan. They tried this. They spent millions of dollars, apparently have not materialized. Now, one question, Dr. Kakar, I'd like to ask you. The non-primary, there's no primary. Let's say you're doing a groin, let's say you have you think you do operate on a hernia, femoral hernia in the groin, and the pathologist will tell you there's a black node, and this is melanoma. So you look at this fellow from top, the head to toes. You did every test you can think about, CT, MR, PETs. You have no primary. What would you do?
You would do a complete lymphadenectomy, and if you're saying that you've looked everywhere, the other areas to look for would be doing a colonoscopy, looking at the anal canal as well, because they can also cause lymph node in the groin region, and it won't be seen on an obvious clinical exam. But you would go ahead and do a complete lymphadenectomy for that, because even if you don't find the primary, as some of the trials showed, it's at least cytoreduction is what you're doing. But if you can't see it...
What do you think?
About 30% based on some of the studies that they have shown, and it also depends upon as we had mentioned about the biology and about the molecular basis of that.
It's not bad, 35 to 55%.
Actually, the medical oncologist would probably treat the patient too.
Another thing you touch on, debulking. Unfortunately, we don't have an additive drugs to give that work against melanoma. This is why debulking is a big question mark. It's not like on any other tumor, like Dr. Stewart mentioned. You can cut down the load of cancer. We don't have good drugs, immunological or interleukin, whatever, at the moment, at the state of the art.
Anything else for Dr. Kakar? Anything else to add, Dr. Chhitoy? Don't get it. Sunblock works?
The whole issue of actually sun and melanoma has been, believe it or not, debated to some extent. So where people talk about, how really a strong predictor that really is, but there is some debate over that issue.
All righty, thank you.